and this is your session stroke workshop on anaesthetics. Okay, and the way we're going to play this is I'm just going to give you a little bit of a short presentation, a little bit about, well, I'm going to plug anaesthetics for about 2 minutes, and then we'll have a little chat about airway management. We'll go through some basic airway management skills and then a few advanced airway management skills. We'll talk them through and then very briefly, and then we'll get you up with the mannequins. We'll split into a couple of groups and you can all have a little go at doing some of the manoeuvres. Alright, that seems reasonable. Just a quick plug of anaesthetics if anybody's thinking about career choice at this moment. I know some of you are still early stages in medical school life, but some of you might be budding anaesthetists. But it is a very good career choice, and I'm saying that because I'm biased. But this little, I find this in our Royal College of Anaesthetists website, which I thought quite nicely basically puts everything together of the benefits of anaesthetics as a specialty. Because we do get to deal with patients, but some of the time they're asleep, which is good. So sometimes we don't have to talk to them. And it's also a bit of a balance. You do get to do quite a lot of clinical skills. You get to put lines in, advanced airway skills, chest drains, all those more exciting stuff, but not quite to the surgical level. So if you don't want to be a budding surgeon, you still get to do some interesting things. It's varied. You get a lot of chance to teach because there's a lot of one-on-one teaching. And basically, but there is a lot of basic science in there, a lot of physiology, a lot of pharmacology, a lot of physics. Which in our stream and our training stream, we have quite rigorous exams that you have to pass. Basically, I don't know if it's the same in other countries. And it's just continually learning, really, but it's a really enjoyable specialty. It's very well supervised. You're never really left on your own. Yeah, I would recommend it to most people. We work pretty much everywhere in the hospital. There's not many places that we don't get to or aren't called to, which is also good because you're not stuck in one place. Spend most of it in the theatre, but it's very varied in terms of specialties that you can cover, from neuro, cardiac, paediatrics, obstetrics. We cover lots of different things. But you're out on the wards doing pre-op assessments, post-op assessments, pain management. You're given obstetric analgesia. If you want to do ITU, as an anaesthetist, it's a good basis for ITU. We're in A&E a lot. Often the first people called for trauma calls, airway management in A&E. And also hospital transfers, you get to go out occasionally. And we do the odd clinic. Not many though, which is one of the benefits in my house, 2 clinics. But pre-op clinics, pain management clinics, ITU, post-ITU clinics. And I've just put this briefly, just so you can look at, if you think you are some of the things in the top, then I would probably recommend anaesthesia. But if you think you might be down near the bottom, then it's probably not something that's for you. So if you're good at communication, you're sociable, you don't mind working in isolation at times, and you don't mind not being seen as a leader, because that's often the case. It is a certain specialty, but it's not the same as being subservient, I was just saying. You have an interest in gadgets, because we do like to play with things, and you enjoy pharmacology, physiology, you're flexible, you think well under pressure, and you're innovative and have a bit of research orientation. If you don't like stress, and you want to be in the limelight all the time like a surgeon, then anaesthetics is not for you. And if you like regular meals, and much as you may think, we don't sit around in the coffee room all day, which is some people think we do. Right, on to the, that's my plug for anaesthetics. Airway and breathing, so that's our bread and butter stuff, airway and breathing. So we're just going to talk a little bit about basic skills and management of the airway. So these are some of the common causes of airway compromise, some of the common causes why people might call an anaesthetist. And usually you can split the reasons up into the 3 different anatomical areas, so the upper airway, the larynx, and the lower airway. Okay? So the upper airway, the biggest thing is the tongue. It's the tongue that always gets in the way, and the tongue that obstructs most airways, and simple airway manoeuvres of a head tilt chin lift or a jaw thrust will relieve that obstruction almost straight away. Okay? And that's usually due to patients that are unconscious, reduced levels of consciousness. They may have a big tongue, due to allergy, anaphylaxis, or anatomically a big tongue due to some congenital problem. Blood and vomit, that's also the most common one in A&E, where they've regurgitated or they've had trauma to the airway. And direct injury, so they've just got direct blow to the face that's causing problems. In the larynx, again, foreign material, so they've aspirated something. Burns is a big thing in the larynx, so they've had inhalation and they're basically starting to swell, so they've got swelling. Soft tissue swelling, again, anaphylaxis. And then laryngospasm, which is when the larynx just basically closes, and it's usually due to irritation of some sort. And then lower airway, again, secretions, blood, bronchospasm, again, aspiration of vomit around the gastric contents. So assessment of airway, so like everything we do, is look, listen and feel, which if any of you have done BLS, you might have covered that. But the main things are basically look to see if the chest is rising and falling normally, or if there's any abnormal abdominal movement, which is paradoxical to the chest movement, which might suggest that they've got an obstructed airway. Listening, you're listening for any odd noises, gurgling, sort of stridor, any of those kind of noises that might suggest that they've got a problem with their airway. And then feel, can you actually feel air? Are they actually managing to expire air? So some of the signs that you might hear, so snoring, which is usually due to obstruction of the upper airway due to the tongue, and again that's usually relieved by simple airway manoeuvres. Gurgling, that's usually due because there's liquid in there, so they're making horrible gurgling noises, and that's usually cleared by suctioning out their airway. Wheezing is usually a sign of asthma or bronchospasm. Inspiratory stridor, which is usually due to an obstruction of the larynx but above the cords. And then hoarse voice, which can be due to edema and vocal cord problems. I might give you that clue. And it's good to say that normal breathing is quiet, but complete airway obstruction is silent. Okay, so you won't hear anything. So be wary of that sound in the chest. Signs that you might look for when you're looking at your patient: heel tug, which might suggest tension in the thorax, problems from that point of view, or collapse. Use of accessory muscles, so are they working hard? So intercostal, subcostal recession. Shallow, rapid respiration, so they're not taking adequate tidal volumes, they're breathing really fast. That may not necessarily be a primary airway problem, that may be a problem due to the conscious level or a metabolic problem. Reduced conscious level, obviously cyanosis, cyanide blue. And as I talked about, the abdominal respiration, so that's seasonal paradoxical movement. So basic airway management, oxygen is the key. Basically, get oxygen on your patient, because hypoxia kills people. So high flow oxygen via an ordinary breathing mask, which we've got one here, and we'll just show you that and how to set that up. Head tilt, chin lift, which I'm sure most of you have probably come across. Basic manoeuvre, and in basic life support you'll come across that. Thing to remember, if you suspect a C-spine injury, then you should tilt their head. You need to keep their neck still. So you might want to consider a jaw thrust, which we will show you how to do a jaw thrust on the mannequin. The key with that as well is don't do that if you don't know how to do it, because it can actually cause more problems if you don't know how to cause further obstruction. Suction, most A&E department spaces will have suction available, but just remember to be cautious with it. Don't start sticking it down the back of their throat, making them gag and then risking them vomiting. Gentle suction, make sure you can always see where you're going with suction. And then removal of foreign bodies only if you can see it and you can get it. Okay, if it's right down at the back, don't risk going in there to get it, because you risk pushing it further back and actually making the situation a lot worse. Okay? And if you haven't excluded a C-spine injury, the patient will be blocked with, if they're in A&E, with a collar on. And if you're going to do anything with their airway and you take that off, you always need manual inline stabilisation so that neck stays still. Okay. So that's basic airway manoeuvres: head tilt, chin lift, and a jaw thrust. And with everything we do, you always go back and reassess, always go back, look, listen and feel. Has what I've just done made a difference? Okay? If it's made a difference, then fair enough, I might be happy and I can move on. If it hasn't made a difference, then I need to take things further and move on to different manoeuvres. So oral airways, or an oropharyngeal airways, again we've got some here, so we'll show you them. Different sizes, depending on the size, usually different colours too. 3 and 4 is usually the sizes we use. But to size a Goodell airway, it's basically from the incisors round to the angle of the jaw. Okay, and again we'll show you that on the mannequin, and you can practice sizing it. Okay, and then to put them in adults, we put them in upside down. Okay, get past basically the hard palate, and then once you're in, turn them round 380 degrees. Okay, to flip round to the normal position. Again, we will show you that because it's much easier to demonstrate that on the mannequin. In children, we tend to put them in normally, okay, because their hard palate is actually a lot softer, and you risk damaging their palate if you try and do it upside down. You can put it in the normal way if you've got some way of sort of lifting up the tongue, so a tongue depressor or a laryngoscope, you could just pop it in the normal way. Nasopharyngeal airways, again sizing. Some people just look at the size of the nostril and look at and basically see which one looks like the right size, but you can size it from the earlobe, nostril to the earlobe, or to the angle of the jaw again. Again, they come in different sizes, which we'll show you. They tend to be better tolerated in semi-conscious patients. If you put a Goodell in and it's tolerated, those patients have got a very reduced GCS. The risk with the Goodell is in a patient who's semi-conscious or conscious. If you put a Goodell in, they'll not tolerate it. In worst case scenario, they'll spit it, or best case scenario, they'll spit it out. Worst case scenario, they'll actually vomit and cause a mess. So if you think they won't tolerate a Goodell, then you can try a nasopharyngeal airway first. Okay, and that just goes down through the nose. Again, we'll show you the technique of putting that in. Some of these newer ones have got a big flange at the end to stop it going down past the nostril, but some of the older ones have to have a pin attached so that it doesn't go too far down and doesn't go past the nostril, which can happen. So moving on to advanced airway management, okay, bag mask ventilation. So you've got a patient who's not making adequate respiratory effort. You've tried basic airway manoeuvres, you've tried putting airway adjuncts down, so you need to basically help them out with their breathing. So you can do that with a bag valve mask, which we have got one of, which again you can do as a one-person or a two-person technique. One-person technique, when you've not done it before, can be quite tricky, or if you've got small hands like me, especially on these mannequins. So don't be afraid to get two of you doing it, someone to squeeze the bag and someone to hold the mask on, because the important thing is getting a good seal and getting air into the patient. So don't be afraid to ask, and don't try and manage by yourself if it's not working. Okay. And you basically can get quite high concentrations of oxygen using that, up to 85%. The reservoir bag on and 10 litres of oxygen dialed up on your oxygen supply. LMAs, again another advanced airway technique, but are sometimes useful in a situation where you're not comfortable intubating a patient, so in cardiac arrest situations, or paramedics out in the field use it quite a lot before they come into hospital. Because they're quite easy to put in, and again we'll show you how to put them in. They can be used if you've got a difficult airway, if you've got someone that you're worried you might not be able to intubate, and as a backup. Also, if you can't bag valve mask someone, sometimes it's worth trying them with an LNA. However, if your patient's awake, they won't tolerate it, and especially those with full stomachs, and the same problems with the Goodell. You just risk you risk them actually vomiting and causing more problems. If they can't open their mouth very easily, it's not easy to get an LMA in. Or also if they've got lots of facial fractures or abnormal anatomy, they might not be the easiest thing to use. And the limitations, if you try and ventilate someone and they've got a lot of high pressures in the airway, then you potentially get a leak and you might not adequately ventilate them. You don't protect the airway because there's the risk of basically gastric contents slipping down past and going into the lungs. And again, the laryngospasm we talked about if they're semi-conscious or conscious. And you may not be able to do continuous chest compressions like you can with ET tube, where you can do continuous and you don't have to worry because of the leak. You've got that risk of oxygen leak, which obviously is risky when you're defibrillating someone. Right, I'll not talk about intubation for the minute. If we get time at the end, we'll talk a little bit about intubating, because we don't have laryngoscopes here, so we can't really practice it.
Basically, it's just tip the head. So, lift the chin. So this is tip the chin. Because, for example, attachment patient who is lying flat, they may have some block at the back of their. So you sniff the morning. What you do is, for example, so the patient is, so you position your patient. Patient is snoring. So when you hear the patient is snoring, you know that there may be a bit of chin.
Exactly. So I have
obviously
just
this
look
is only
inside to see if there's an obstruction, and after that, take it out, or if there's blood, I have to
straight line between the lungs,
suction it.
and the mouth. So what you do is, this is the chin. Easier. You push it out to get air from the outside, oxygen from the outside into the lungs. Now, so that can anyone remember the other airway obstruction do at the back of the throat? Okay, if that fails, what do you do? Or if someone has a trauma to road traffic accident patient.
Yes, I
so
have
if someone,
to
you think someone's like got
exactly, and to leave it, I have to take it to the hospital. I'm not allowed to do anything.
You're in hospital now, you're in A&E.
Okay, that's the accident.
Yes, no, you're in A&E.
No collar, you ask someone to hold it, and then do a jaw thrust. You'll also know that it's not very ridiculous. So what you do is, this is the angle of the angle. You push it up. Semi-conscious, you push it up. Obviously at the same time you are not conscious, so it can be a helpful way of kind of assessing their conscious. Okay, so I mean you don't have to. This is a non-reprieve mask. How you differentiate is because there's a camera back here. So what this do is it produces an oxygen reservoir in this bag, so it increases the respiratory percentage of the oxygen. So all trauma patients, basically, to me, everyone in A&E get this, and then we'll decide whether to use a normal mask or something else. Any questions so far? Yeah. So it's oropharyngeal airway.
Collapsed, and people often just put it on and walk away. And it actually then doesn't work. What you need to do is when you've turned the oxygen on, you need to put your hand or your finger over the valve, let the bag expand, then put it on your patient, because otherwise you just end up with a collapse.
Where does the oxygen attach?
Just, okay.
The reason you don't need to too long, oxygen pipe goes in and stimulate the gag reflex. So like we were saying, if the patient's semi-conscious, you put one of these in, it's too long. Pin. This is the old-fashioned way. The reason why they have a pin, you do because you can use it. So most of the time, they don't have to be completely unconscious, so they can be kind of steady moving around a little bit. But the danger is as they become more conscious, they won't tolerate it. So they'll either spit it out, or as we said, the worst stuff. Now this one as well, so that's the right way around, obviously. And it will go all the way back of the throat. So what that does is it makes it so easy.
Same with an NG tube.
If I just get the seal there, you can see that it's very easy. Alright, so sometimes before we put this thing, we put a spray to make it easier to sort of constrict the blood airways. Good adding to have. So that's that. Does anyone have your there you go. So don't have to do details or anything. No, you don't have. When you put it in to begin with, you can just put it in like that. Yeah.
Is there?
It's a bit. It's that. So I mean,
awake patients will tolerate
because when a patient is sort of trying to.
That's really where I have to put the mask on. So we didn't check the.
That's a sign that they're improving and their conscious level is improving. Anyone else? Yeah.
Okay.
No, practice now at this stage, you have a look. So you just open the mouth, have a look if there's anything obvious. If there is, you can put your fingers in as a pincer and take it out like that. Otherwise, you should do anything. It's the same as
suction. This patient doesn't have a fracture, so well, airway.
Okay, so everyone
oropharyngeal airway, oral for oral.
Any questions about it at all?
I usually use 3 different sizes. There's
So does anyone know
a green one,
what
which is
these
a
are?
smaller size. There's a orange. There's a red.
Yeah,
So, to make it easy to remember,
so these are both
green for 7, and
so when
so
we
you
might
go in like
use
that.
this, anyone remember when we might use
Then
it,
once you
pharyngeal airway
sort of
goes to an oral
go in a
pharyngeal
bit
airway.
and then you turn. It should.
Yeah.
The function
Yeah,
is
yeah,
it will
so
lift the
patient,
tongue
I mean, they can be conscious.
sort of forward and
So
back.
it is, so,
Okay. I guess for this, everyone should know.
Some people use
I
it
love
to say this like that, in terms of the size, you know, you sort of look at the
Size,
finger of the patient and see sort of how wide it is, but that's function, so not really reliable. So obviously,
Like that, and then we will know, yeah. It's funny, I remember.
just get
Like that, and then you turn it.
we can spray they don't. So obviously when it's sitting in, it's going to be in that position, but in order to actually get it into the nose, you kind of go over start first, and hold out the two that's more open, and that changes throughout the day. So you know, just different times of the day. So you press against your nostril, breathe in one, and breathe in the other. So if you all do that now, you'll notice that one of them is sort of concerned about. Yeah, exactly. Yeah. So if you've got an interruption between
To the angle of the mouth.
but these are well tolerated even in most people. So yeah, if you've got anyone else want to go? So
It depends what you're doing to try to have their airway or stop them biting your tongue.
So that's why we have a back wall mask
so
whereby
you have to put
you
around
can rest,
the skull there.
and then that will drive oxygen into
So
the patient.
the
So
reason you do that,
essentially,
but not
these
even.
two
So if this was
fingers, the thumb and the index finger,
and then
sort
if
of
it's nice and cushy,
pushed it up against the mask.
seal.
And at the same time, with this maneuver, you can do a head tip chin lift on the patient. Sort of not having a good seal in the patient's airway is sort of not very good. You can use 2 hands to do it, and then
basically
ask the, one of your colleagues or anyone to back
shot and then
the
you're not
patient.
shifting any air at all.
And just
So
remember,
can
you
get
don't have to
the
go.
worst now, I do know
It's just gentle.
I do know some
You don't go mental.
in themselves rather
You do see it.
So you can tolerate it with patients. We use them a lot in theatre.
Good technique even on the ward.
But you don't want
In an
to
arrest situation, you can
use
do
it wet
good
across
bag
the
valve
view
ventilation.
or full stomach.
You don't need to worry about
This
anything
gives
else
no
like
protection
elevators,
from
tubes.
regurgitation.
As long as you are
Gastric
oxygenating
processes
the
will come
patient,
off the back of the throat.
patients
down
will
into
die
your
of
airway. So
hypoxia.
it's not like,
And that's what you need to make sure the oxygen's
protect
getting
your
into
airway
the
from
patient.
soiling. This is all about oxygenation, not about sort of access to the mouth. So in some patients, you do that, and then you
Right then.
get it in the right thing.
This is usually okay,
And then
yeah,
you can
but
put
yes,
it down.
if you're lucky enough to have one of
like
those.
that.
And you put that as well as
You can, yeah, you can easily just put a Goodell, because you probably will be at that stage that you'll pop to Goodell, and it does make your life easier.
Chest all to it, and title carbon dioxide everyone. So then you just touch it.
Yeah, I've got some more.
It would be a bit difficult if you
Squeeze it. Does
Yeah.
anyone go?
I'm delicate.
what I would recommend
Got a
is
decent
your
amount of time.
Little pinky.
I don't reach. No, I'm joking. I'm joking.
That's all the pushes and things to show you that.
Try it with 2 hands, it does make it easier.
So you can see.
Can you help me? Yeah.
Thank you.
And it's less tiring as well.
Does anyone have any questions at all? Put it the other way around, so you put your index finger there, like,
yeah,
yeah, that's good, yeah.
You really need to be on the baby hands. And also baby, remember, it's neutral position with under ones, because they've got a big head, large eyes. So by head tilting, you actually get a situation where they're neutral position.
time, because when you put it into the patient, it makes a good seal on the larynx of the patient. So you imagine the larynx is here, you put it in, you make a good seal on the larynx. So this is quite a good instrument actually. So before we put this thing in, you have to cover it with gel, make it a bit bigger. And then how you put it in is, I would always get someone to sort of open the lower jaw a bit, hold it like a pencil. I'm left-handed, and just push it in.
So with an element, you can put it in. You don't need to give them muscle relaxant. You don't need to try and.
It's a bit tight, but and on the laryngeal mask airway, there is a line. This is a black line here, and this black line should always face yourself, because when it faces yourself, you know that this thing is making a good seal on the larynx. Any question?
Yeah. So what you do, you put the mask on like that. So you C shape over the mask.
Your fingers.
So push that down, and then when you do the 3 fingers, you put it on the angle of the jaw, on the bone rather than on the soft tissue.
Sometimes, as I say, it's not easy, so asking someone just to do a jaw test. If they're a little light, you say, or they just don't like it, then I'll just close it.
Obviously, go from the mouth to the trachea. This one is a size 9.
Airway might be in trouble that you need to do something about. Basic airway manoeuvres, and they're going to be your lifesaver basically. If you do the basic airway manoeuvres correctly, then you will get some air into that patient and get some oxygenation to that patient. If they don't work, then you move on to more advanced techniques. So you can use your simple airway abdoms, you can use pharyngeal.
Left-handed in a minute if that's easier. The whole point is, it's called the sniff in the morning air position, because if you imagine if you're doing it, and you sniff the morning air, it basically opens up your airway, so there's least resistance to airflow. So that's the position you want to get the patient in. So you just tilting the head back, like that, and lifting the chin up. Now you can see, obviously this is only a model, and it's not quite the same as a proper patient, but you can see that you're opening up the airway, so there's more of a straight line between the lungs, trachea, and the mouth, and that makes it easier to get air from the outside. Trauma to the spinal cord, and it can end up paralysed. Obviously, you want to avoid that. So you can do a jaw thrust, and the jaw thrust is literally what it says. So you put your fingers behind the angle of the jaw, make sure they're on the jaw, so they're on the bone rather than on the soft tissue. Because if they're on the soft tissue, you can cause more swelling and damage. So you put your fingers on the jaw there, and then you just lift in the jaw forward. It's not sort of particularly easy on these models, but if you put your own fingers, also know that it's not a very comfortable thing to have done if you're conscious. So a lot of these patients are unconscious, so they don't feel it. But if you've got someone who flanges on, to stop it going too far into the nose. But as Zara was saying when she talked to you at the beginning, the older ones in the UK had the safety pin on, just to stop it going too far. They don't tend to be, you don't tend to see them like that anymore, but you do occasionally. Slightly big, and then also you can do the same thing. So they sort of do earlobe to the jaw, and they tend to put it on the right, the patient's right nostril first, but you can do either, it doesn't matter. So you go up first of all, so it goes into the nose, and then once you're through the back of the nose, you can readjust and just go down. And then it stays like that. So obviously you can put an oxygen face mask if the patient's conscious, but if they're sort of unconscious and the mouth shut, I'll sort of try and shut the mouth. It's difficult to do it completely, but you can see that you're still sort of able to shift it. Yeah, that's good. Yeah.
Too far?
No. I mean, to be honest, unless you're sort of really, really vigorous, you're not going to be able to push it too far, because you'll push it and then you'll feel a resistance. So that's yeah. I mean, normally in a patient, in a normal patient, you probably can't see it because it'll be too dark at the back of the throat anyway. But yeah, you can see the top of it just about in these ones. Yeah, so that's fine. Yeah, and you can see as you when I pulled it out there, it was still in the right image. You can make it two-handed. Do you want to go ahead?
Most of the time.
They work really well, yeah. Actually,
Are you thinking about doing on a